welcome to another in the series of the National Institute for Clinical Excellence, NICE, seminars delivered from the Institute of Health Studies in Plymouth. Last time in this series we enjoyed receiving information from Dr. Morag Prowse from the Institute at Plymouth regarding the treatment of morbid obesity and the NICE guidelines relevant to the subject. If you missed that, don't worry, there are video copies available of that session for viewing. These copies, and those of other IHS seminars, are kept on each site for perusal and teaching purposes. This month's NICE seminar will be delivered by another of our Institute of Health Studies colleagues, Jennifer Kevern. Jennifer, who's Senior Lecturer at Exeter, will consider the NICE guidance on the use of debriding agents and specialist wound care for difficult to heal surgical wounds, plus the clinical guideline on the pressure ulcer risk assessment and prevention. Jennifer's presentation will be followed by studio and site discussion. Joining us to assist in our discussions are two experts in the field. Maya Fear, Tissue Viability Nurse Specialist for Plymouth Primary Care Trust, South Hams and West Devon PCTs, and Martin Butcher, Skin and Wound Care Service Manager and Clinical Nurse Specialist at Plymouth Hospitals Trust. Thank you very much for taking the time to be here. I'm also very aware that there's considerable further experience and interest locally in both the Institute of Health Studies and the wider peninsula. Those of you who fall into this group, please do make contact with your comments and queries to add to our debate. The telephone number to call is 01752 233 646 and the email address is studio@plymouth.ac.uk. Calls will be received following the presentation, which will be about 2:30. Please do share your thoughts. Your contributions are most valuable. Now, without further delay, I'd like to hand over to Jennifer.
Hello, good afternoon. For the first part of this presentation, I'm going to be looking at the research-based evidence that supported the development of the NICE guidance on debriding agents and specialist wound care clinics for difficult to heal surgical wounds. And then I'll be looking at the evidence for the inherited guideline on pressure ulcer risk assessment and prevention. When constructors of guidelines, when authors of guidelines on the clinical effectiveness of a treatment or an intervention, what they want to find is good quality randomized controlled trials. Randomized controlled trials that produce valid, unbiased and robust evidence for the effectiveness of the particular intervention or treatment. A randomized controlled trial is a trial in which subjects are randomly assigned to either the experimental group, the intervention group, or the control group, and then the outcomes, the dependent outcomes, are compared between the two groups. One thing that will set the authors will really light their fire is to find systematic reviews, that is a collection of randomized controlled trials that is going to provide good, sound, quality evidence for the particular intervention that they are planning. Systematic reviews are important because they have very clear selection criteria, they're very comprehensive, and they also use explicit guidelines on how they appraise the information, the studies, for methodological rigor. When we're looking at evidence for the development of guidelines, often people talk about a hierarchy or a continuum of different levels of evidence. And right at the top, what researchers really want to find, or what guideline constructors really want to find, is strong evidence from at least one systematic review of randomized controlled trials that support the intervention and that there is a low risk of bias in those studies. And going down the scale, we move from strong evidence from well-designed randomized controlled trials two descriptive studies and evidence that is perhaps more informal and based on the clinician's expert opinion, clinical experience, and so on, evidence from expert committees. So looking at first of all, the background to this study, the use of debriding agents and specialist wound care clinics for difficult to heal surgical wounds. The technology appraisal document talks a great deal about the factors that provided the rationale for the development of this guideline. First of all, most surgical wounds heal normally and quite quickly, but delays to healing are caused by a number of factors. Intrinsic factors such as the patient's any other existing morbidity, such as diabetes, their nutritional status, their circulation, their age, and so on, and local factors to do with the development of material or infection within the wound. We have no reliable epidemiological data on the number of surgical wounds that become difficult to heal. There are around 6 million surgical wounds every year in the NHS in England and Wales, and it is estimated that there are probably 21,000 become difficult to heal for a variety of reasons, but that could be an underestimate. The reviewers also noted that the care of these patients is shared between the hospital and the community, but with a growing trend to care provision within the community, and that practitioners looking after these wounds require access to high levels of knowledge and skill and advice from a variety of clinical disciplines, and believe that maybe we should have expert services for the most intractable of wounds. Debridement is literally the removal of debris, devitalized, necrotic tissue, infected tissue, or fibrin from a wound. And there are different methods of debridement. Surgical methods, excising the material from the wound, chemical methods, mechanical, biosurgical, and autolytic. Autolytic, which is a method which promotes the body's own autonomous debridement and wound healing processes. There are a range of wound care products that are thought to promote autolytic healing. Alginate dressings, different foam dressings, various types of dressings which collectively are known as modern dressings. And related to debridement is the frequency with which the dressings are changed and the patient's acceptability of the particular type of dressing that they are being required to use. The actual cost to the NHS of these difficult to heal surgical wounds has not been measured. As I've said, the epidemiology is quite poor, but there is a growing awareness that the healthcare costs are not only the unit cost of the dressing, but also the frequency that dressing needs changing, that is the cost of the nurse's time quite often over a period of time, and also cost to the patients themselves. So the number of patients affected is not known, and we do know that clinical practice varies, and also the reviewers were aware that in the future we are likely to see more difficult to heal surgical wounds with radical surgery, the ageing population, and also the reality of hospital-acquired infections. So to look at the treatment, the debriding agents for difficult to heal surgical wounds, the NICE commissioned what they described as a rapid systematic review. And like all good systematic reviews, there were very clear objectives. The first was to determine the clinical and cost effectiveness of debriding agents in the treatment of these particular wounds. And like all good systematic reviews, the reviewers were looking at very clear-cut focus. They had to be this particular type of surgical wound. Any other surgical wound was eliminated from their search. There had to be clear specification of wound healing rates. And the reviewers, when they looked at studies, there were 2 independent reviewers, and a third person was consulted in order to achieve consensus. The second objective was to evaluate the clinical and cost effectiveness of treating patients in specialist wound care clinics. When the reviewers of the systematic review looked at the evidence, they were using two outcomes, wound healing and cost, and they found 17 trials, all using autolytic methods of debridement, but only 13 of those were considered useful for this particular type of wound. And they looked at wounds such as perineal wounds, abdominal breakdown in abdominal wounds, pinodial sinuses, abscesses, and so on. So they looked at different types of wound, different types of surgical dressing, and many of the studies just looked at one method of treatment. In 3 studies, they compared one surgical dressing with another. Only 3 of the 13 studies compared the different type of the different type of modern dressing. They didn't find a single study that investigated other types of debridement, such as surgical, in difficult to heal surgical wounds. All trials were looking at autolytic methods of debridement. The quality of the evidence was considered in the technology appraisal document. Many of these studies had methodological flaws. In particular, the small sample sizes for the studies was noted with a median of 43. And in a total of 13 controlled trials, there were less than 500 patient subjects. Many studies, it was found, did not report how they randomized patients to the treatment group or the experimental group, and neither did they report whether the assessors of the outcome measures, whether they had been blinded as to which particular group the subjects had been allocated to. Again, many studies didn't report the important baseline characteristics of the wound, how severe the wound was before they started the treatment. Neither did they report on relevant patient characteristics, such as their age or clinical condition, which are likely to affect the healing time of their wound. Other limitations were that when they calculated healing times, they often didn't give a very clear result. Many studies used a mean rather than a median, which was affected by extremes of the outliers in their results. And also, if the wound didn't heal at all, then it was very difficult to calculate mean healing times. And finally, the statistical tests that they used to compare the effectiveness of the treatment compared to the control group were often not very clearly reported. So it was not possible to pool the results of the study and to provide a meta-analysis of the effectiveness. So therefore, the results of these studies should be interpreted with caution due to their relatively poor quality and the unknown effects of potential confounding factors which could bias the results. Looking at clinical effectiveness, they couldn't find any controlled trial that demonstrated that one type of modern dressing was superior to another. There was, however, some evidence to suggest that patients would prefer one type of dressing to another, particularly in more subjective assessments of pain, dressing performance, the management of exudate, and that kind of thing. But because these studies were unblinded, these secondary benefits were felt possibly to be perhaps biased. In relation to cost effectiveness, there were only 4 economic evaluations, no evaluations comparing the 2 different types of modern dressing or of specialist wound clinics. There were no evaluations of the cost effectiveness of wound clinics. There was some evidence that modern dressings are lower in cost, partly because they required less frequent changing. But it should be stressed that the quality for the effectiveness of cost and clinical effectiveness analysis was poor. So in the guidance they're saying there's no evidence for any particular method of debridement, but that modern dressings may reduce pain and be acceptable to patients. The choice of guidance, they concluded, should really be on patient acceptability and minimizing cost. So therefore, if one type of treatment was no more or less effective than another, then cost minimization was a suggested criterion of choice. And that the treatment of these patients required a structured, multi-professional approach to care. There was a lot of implications mentioned regarding future research. The reviewers would like to see more multi-centre trials comparing different types of modern dressing, economic evaluations of modern dressings, research into other debriding methods, and also studies looking at clinical and cost effectiveness of specialist wound care clinics, and more epidemiological research on the prevalence and cost to the NHS of these particular types of surgical wound. Turning now to the second guideline, this is the NICE guidance on pressure ulcer risk assessment and prevention. This is an inherited guideline, inherited from the Royal College of Nursing, and it was developed by a multi-professional group of people, including carers and users. The guideline had three aims. The first was to provide a good means for assessing those at risk of pressure ulcer development, and to provide an understanding of the effective interventions for preventing pressure ulcer development. And thirdly, to reduce the likelihood of unproven or harmful methods of assessment and prevention. This was a particularly complex guideline because what the authors were trying to do was to identify several links, several criteria that would relate to the assessment and the management in the prevention of pressure ulcers. And so they identified 9 separate criteria, and for each criterion they were looking for evidence, both informal evidence in terms of best practice, and also formal evidence in terms of a sound, robust research base. They had their own scales for evaluating the evidence. The first one was generally good, consistent finding in a majority of acceptable studies. The second level was based on a single acceptable study or weak and inconsistent findings from a number of acceptable studies. And thirdly, where there was limited scientific evidence which doesn't meet the criteria of acceptable studies, they would include expert opinion. So the guideline development team described themselves as a nominal group, and they worked towards a formal consensus development, and their aim was to find and appraise and then to integrate the different evidence sources, and where there was a weak research base, to agree recommendations based on current best practice. 2 clinical issues out of that the list of 9 levels, or 9 criteria that they were looking at. There were only 2 clinical issues where they could find a systematic review to provide evidence at level 1. The first one was on risk assessment scales, where they found studies that had fairly clear-cut criteria for selection of patients, the design of the studies, the follow-up criteria, and the measurement and tests of reliability. And the other source of evidence, the other type of criterion for which they had evidence, was on pressure redistributing devices, and they found 2 systematic reviews for that. The remaining level of evidence to support this guideline was appraised at level 3. Looking at the 2 systematic reviews, the authors reported that on the whole they were of fairly poor quality. The sort of things that they identified as being weak was, for example, a lack of baseline comparability between the 2 groups, or the measurement of the problem in the first place, There was a very poor description of the ulcer assessment, lack of blinding in the studies as reported in the other guidance, often inadequate sampling and attention to randomization. And in particular, in the first study, the first systematic review on pressure ulcer assessment, many studies gave little attention to inter-rater reliability, which is very important. In other words, studies that were looking at assessment scales, they often didn't report whether there was reliability between the assessors. So based on that sort of cautious appraisal of the evidence, through the process of consensus development of the guideline, they felt that there was some research evidence that could be translated into recommendations. First of all, that there's insufficient evidence to recommend using risk assessment scores on their own, and that decisions should be made based on holistic assessment of an individual patient's risk. And secondly, there is evidence to support the recommendation that individuals at risk of developing pressure ulcers should not be placed on standard foam mattresses. And there were also recommendations for future research. So in the publication of the guidelines, each of the 9 issues are identified, the recommendations are made, and then the levels of evidence to support those recommendations are often given, and they often refer to the consensus development and the expert opinion. The recommendations for future research include, is very, very large. They include more attention to methodological standards throughout, the need for well-designed, independent and multi-centered randomized controlled trials of the different types of pressure devices in a different variety of settings. And that's it. Thank you.
Okay, well, back to me. Thank you very much indeed, Jenny, for a very helpful presentation. It's now our opportunity to discuss some of the issues that Jenny has referred to, and your opportunity to phone in with any queries in relation to Jenny's presentation, or indeed wider issues in relation to tissue viability. Telephone number on the screen, do give us a call. I wonder if I can start off following Jenny's final comments there in relation to some of the future research that's required, and whether indeed in the Southwest there is already research happening, whether there's already research planned to tie in with the recommendations, identifying that we need to look across multi-centres through randomised controlled trial approaches to get the information that we need. Perhaps I can start with Martin. Have you got...
Well, certainly there's great plans to move things forward. The tissue viability nurses in the Southwest formed together in a regional group. Between us, we're aiming to set up studies in the next year or two to actually start moving things forward as a multi-centred trial site. We feel that we've got an ideal opportunity to do that, in that we have a good client group, we have a good group of tissue viability nurses, and we've already got a good deal of expertise in the Southwest.
Excellent. I might come and pick that up a little bit further in a moment, but I gather we already have a phone call. We have Plymouth on the line.
Hi, it's Ray Jones here from Nottingham in Plymouth.
Hello, Ray.
Excuse my ignorance, but I was wondering what's maggots got to do with all this in terms of the first systematic review? I mean, do maggots come into the cleaning of wounds?
If I can answer that, yes. They do come very much into the removal of devitalised tissue from wounds, particularly where there is soft, sloughy material. Then they have been proven to be very effective, very efficient, and unfortunately the NICE guidelines came out just before the clinical research that showed the cost effectiveness, demonstrated the cost effectiveness when compared with hydrogels in the same situation. So, and we are actually using them. Martin uses them in the hospital in Plymouth, and we actually now use them in the community and community hospitals.
So does that mean then that one of the future lines of research might be to compare that with some of the things already in the NICE guidelines?
Yes, some of that research has been done, and a lot of it continues to be ongoing. The research laboratory that has developed the biosurgical unit and the use of maggots collects a database on a regular basis from people who are using the therapy, and they're building that up to find more where the therapy is most useful and where it's most cost effective. And that continues as we go through. In fact, we're actually looking ourselves, and Martin and I were discussing earlier, a project that we have lined up to start probably in the new year, looking at the use of maggots, larva therapy, in debridement of particularly chronic wounds where patients have a minimum blood supply, because as Jennifer pointed out to us, with a lot of the products you need a blood supply in order to help them to work efficiently. Maggots don't need a blood supply.
Does that help you, Ray? Yep, he's gone. Okay, I wonder if I can follow that up a little further. One of the points that Jenny made when she was referring particularly to the first set of guidelines was in relation to the choice of guidance and focused on patient acceptability. Do patients accept larva therapy?
I mean, Martin's surveying towards me because I do use, we use a fair amount of larva therapy within Plymouth Primary Care Trust and South Hams and West Devon Care Trust, and usually I found I have been asked by the patient for the therapy, and I think, Martin, your experience has probably been the same.
I'd certainly concur with that. The majority of patients that we've used larvae on in the hospital, and there's been a large number now, have actually asked for it. You see it every week in Women's Realm or in the Guardian or whatever else. It's very big on the media these days, and people ask for that. I think the big issue, if I can come back a little bit, the guidelines were set out for acute surgical wounds, and I think this has been one of the problems with the guideline. It wasn't looking at the chronic wound, and many forms of debridement that we use are in fact for chronic wounds rather than the acute wound. And that's probably possibly a failing as such in the guideline itself. If it had a wider brief looking at chronic wound management as well, then I think we would have had a guideline that was actually more user-friendly and actually covered a lot more of the patients that we're likely to come across.
And is there a plan to introduce a secondary guideline to look at the chronic?
Certainly there's been work done. The Centre for Dissemination has actually looked at chronic wound management.
Right.
I don't know if NICE are taking that on board.
Right. And Jenny, you referred earlier when you were talking about the data that had been collected that actually there was very little evidence on surgical debridement for difficult to heal surgical wounds.
Yes, I mean, I think because of the very strict criteria they were using, what they were focusing on, difficult to heal surgical wounds, and then the studies had to have a very clear measurement of healing and so on. So a lot of studies that may have covered these topics, particularly with the biosurgical methods, the use of maggots, is that because they weren't looking at these particular wounds, they were excluded, and that they weren't finding studies that were targeted to this particular focus of difficult to heal surgical wounds. So there may have been studies of surgical methods of debridement of leg ulcers or chronic wounds or other types of wounds, but not on this particular type.
Right, right. Martin, I wonder if I can ask you to share with us what you believe some of the local challenges are with regards to implementing the guidelines.
If we're talking here just the debridement issues, there are numerous issues, I think, with that. There are a wide variety of choices available to us as far as debriding agents, and I think you're quite right in saying that the guidelines highlighted that there hasn't been an awful lot of information showing one is better than the other. I think most clinicians would recognise that surgical debridement is probably the most effective as far as time goes, but it's a costly option if you're taking patients to theatre. Many healthcare professionals, however, do bedside conservative debridement, sharp debridement with instruments, and that raises a whole range of issues about the extended role of all practitioners. Medical staff are trained in sharp debridement, podiatrists are trained, but nurses aren't necessarily. And although historically nurses have actually carried out sharp debridement, there are big issues about patient safety, and that's certainly something that's been fairly high on the agenda recently. As far as topical measures and dressings, I think there are lots of issues regarding cost effectiveness and patient acceptability. Larval therapy is probably the second fastest debriding action for most patients, second to sharp debridement. However, there are obviously some patients who that is not appropriate for, and who succumb to the yuck factor. So you have to have a choice of options there, and no one system is going to work for all patients.
What about hyperbaric therapy?
Hyperbaric therapy works by increasing the amount of oxygen in the tissues and can speed white cell action. Now, white cells, as we know, are essential as debriders. However, for pure debridement, hyperbarics is not really an indication.
Okay. Can I then move to Maya and ask a similar question with regards to the pressure ulcer risk assessment and prevention guideline?
Yeah.
What are going to be some of the challenges in implementing that?
I think some of the challenges were that we'd already started looking at developing our own guidelines, but waiting for the NICE guidelines to come out. And fortunately, a lot of the work we'd already achieved is within the NICE guidelines.
Right.
So that was good. I mean, both Martin and I have had focus groups within our own areas, so that we haven't been dictating our guidelines. We've been looking at what they require as well in order to help them to implement. So we've been linking it very much towards the Essence of Care document, about benchmarking, about what the requirements are in order to make sure that we can achieve best practice. And as far as the risk assessment is concerned, then yes, we have remained closely with Waterloo risk assessment, but realised that it is only a tool that is used to indicate. It's not going to actually tell you exactly which person is going to break down, but it is an indicator.
Right.
It's an aid memoir.
Now, I wonder if I can pick you up there, because we have a question from Bodmin that's been emailed through, and it relates to the risk assessment scorings and Waterfield. I mean, are we still using Waterloo? Sorry, are we still using Norton scales in the area?
I think in Plymouth, then I'd say no, in the majority of cases. I know that within the Hospitals Trust, although you are using Waterloo, you actually have another one that you use on maternity. So that is specific for patients' needs.
The question from Bodmin is, what are some of the factors considered for risk assessment scoring within the tools?
The various risk assessments that are considered within the tools are about continence, about the patient's body weight, about their mobility. And what we've tried to do when we've been developing our guidelines is to say it is not just a number crunching exercise. What we've actually done is develop flow charts to say, look at this, consider the risk factor, but also consider these other things, particular to our patient clientele requirement. And that's what we've done, is link that to that.
Which indeed is leading you to the holistic assessment that is suggested.
Everyone is different, and that's why we've had to look at our equipment differently, because our requirement in specific clinical areas are always going to be different. Slightly different.
And I'm right in thinking that the Waterloo tool also prompts you with regards to the chosen type of mattress, for example, that you might utilise.
It really prompts you as to the level of risk, perceived risk, and from that you take your assessment. I think there are a number of issues, as Maya has pointed out. Risk assessment tools are only as good as the people that are using them. And as has been highlighted within the NICE guidelines, there is two stages to risk assessment. There's the informal and the formal. I think for too many years people have been hung up on the formal risk assessment. You've got to get the numbers down, you must get the numbers down. really that is only one part of it. We need nurses to actually start to use their minds a little bit. I'm not saying they don't, but a lot of people can be blinded by the number and forget about some of the obvious things.
Almost as though the number avoids one looking
That's
laterally at some of the wider issues.
At the end of the day, we have to look at using resources, and part of that is our nurses' time. Is it appropriate for us to actually spend time doing a risk assessment on somebody who, and a formal risk assessment on somebody who obviously is not at risk? You've got a young man comes in for a minor operation, a day case procedure, he's going to be going into theatre for maybe 15, 20 minutes. Is it appropriate for us to actually do a formal risk assessment tool? And certainly NICE seem to be heading towards that isn't an appropriate use of resources. An informal risk assessment tool would be completely
right. That's lovely. It leads me beautifully into another question that's just come from Torbay, which says, is there anything for the patient to do in all this? So what do we do with regards to patient education? What about this young man who needs perhaps an informal risk? Is some earlier education required to ensure that we don't have to put in so much resource on arrival for their surgery?
I think, as far as, if we're talking about the young man, then, for most young men, I think going in for an operation, the big thing would be that they would want to be out of it as soon as possible and get back to normal everyday living. But as far as patients who perhaps have an element of risk, then it's about involving the carers, involving them, telling them about what can be the problem, what are the risk factors, and how they can help themselves to reduce them. And that again is something that both Martin and I have included in our policies, including booklets that you can pass to patients. It can be reinforcing what the nurse has already said and how they can be looking at moving themselves. I appreciate we're sitting in the studio now in one position, and it doesn't take very long before you're thinking, I hope somebody else goes on the camera so I can move position. And this is exactly what you're going to be doing when you're teaching your patients, whether formally or informally.
The guidelines have been quite specific that care is about a partnership between us as healthcare providers and the patient and their informal carers. And when it comes to risk assessment and actually acting on that risk assessment, we have to actually involve all the parties in that. And that means that patients need to be empowered, they need the information, and then we need to make decisions themselves, and we need to work in conjunction with them through that. And that's certainly something that I think tissue viability nurses across the country are working towards, to actually empower patients to make decisions, giving them the information that they need, so that we can actually support them. The days of matron coming, I hate to use the term now, saying we have them back with us now, but matron coming along and telling you you must get out of bed every hour, you must have this or that done, I think are gone. We need to work in partnership.
Working in partnership with regards to clinical risk. What about working in partnership with regards to the research that's required? Are we not quite there yet with this? I'm a little surprised from Jenny's resume of some of the work that's been done, that we flagged in such a pivotal area that the research is actually still quite poor.
I think you need to think about the client group that are involved. If we're looking at pressure ulcers, if we're actually looking at let's say the treatment of pressure ulcers, you often have a group of clients there who would be excluded from randomised controlled studies. They have too many comorbidities. If we're looking at debridement, there are many different types of patients with many different types of problems, and it would be impossible to get a randomised controlled study done on most of those sort of scenarios. So we have to look at possibly poorer quality evidence, which is very legitimate evidence. We need to look at large cohort studies possibly.
Right.
And then look at the individuals within that and then the subgroups within that. And that's something that a randomised controlled study doesn't necessarily do.
Thank you. I'm going to stop you there. I gather we have a call from Plymouth.
Hello, Val and
Hello,
Jennifer
Anne.
and everybody on the panel. I've got a question about looking at environmental factors, in particular how the tissue viability teams working with the control of infection teams as an issue to do with surgical wounds and etc. healing, particularly at the moment as the increase in infections within hospital-acquired infection rates are increasing.
So can you just capture your question again for us, Anne?
Right. How do the tissue viability team see themselves working with the control of infection teams to address some of the environmental issues that may impact on wound infections and control of the same?
Thank you.
Okay. I think it's a union which needs to be developed and moved on. In some areas in the country, there's an extremely close links, i.e. you have a nurse specialist in both tissue viability and infection control. North Devon is one of those. Andrew runs both services. Other parts of the country have different services, with nurses looking just at tissue viability or looking at infection control. Whichever system you have, you need to work together for the patients. I think if we're looking, for instance, at pressure ulcers, one of the issues that's been raised recently is about mattresses. We know mattresses can be or poor quality mattresses can be one of those things that lead to pressure ulcer development. We can put business cases together to get mattress replacement programs in hospitals, but unless we actually work together and try to put a combined business case together, which shows that it's not just about pressure relief, it's about infection control issues, the mattress has a reservoir for bacteria, then we're probably not going to move on.
Okay, thanks. Was that it, Anne?
Yes, thank you very much.
Thank you. We've had another question for Plymouth in relation from Plymouth in relation to the patient education, and the query is there a possibility for trials of different forms of patient education and their effects on subsequent healing?
Nice question. Yes. Yes, there is. I suppose there is the possibility. I mean, what has happened over the years is that a number of people have asked have devised different information booklets for patients. The trouble is that they haven't looked into the other research that surrounds that, which is in regard to how big do you make the print, what colours do you put in there so that people can notice, but some booklets have been developed along those lines. The problem is that because of the expense of the booklets, they're normally sponsored by companies who contain a fair amount, Mr. Martin, of their products involved in it, and we're always so careful about making sure there is no bias. As far as making sure that the patients can understand them and that they are going to benefit from them, then yes, a number have had audits performed on them to see whether they are acceptable and whether the patient had a better idea of the problem after reading them. Our concern as well is, do they come in different languages? And for the majority, they are in English, and it's very expensive to get them translated. The future research on that, well, there is a potential for it, but it would be rather a big piece of research, and if somebody's interested in carrying it out, I could always provide them with some of the booklets, and I'm sure Martin could as well.
Yeah, I mean, it would be most interesting, wouldn't it?
Yes,
because I mean, we all refer back to our student days and consider the pieces of research along the lines of information and prescription against pain and so forth. And I'm sure absolutely right, Plymouth are, in that there is a place here for that sort of piece of work to be undertaken.
Communication is a big factor, I think, in your risk assessment and in the care that you're delivering to your patient and what's happening, as well as the carers and the family. It does very much come down to communication.
There was an area that one of the consultants at the workshop this week discussed at the workshop in relation to pressure ulcer development, and that was when patients are transferred from within departments, for example, waiting on trolleys for radiotherapy. I know there is some research about the development of pressure ulcers, or the risk of pressure ulcer development in theatre, but things like X-ray and radiotherapy in these kind of areas, that we did feel we do need more research on that, and perhaps some observational studies of what actually happens when patients are transferred from bed to trolley to another department and back again, which seems to be an area when patients do develop or could be at greater risk of developing pressure ulcers, and we may need a bit more evidence about what's going on there. And that was just one area of research that was identified by the consultant this week.
One of the things that came up from that as well is that there has been work done. I mean, Bridal did the work in the theatres, and I think that some of that has been taken up within interdepartmental studies, and particularly with tissue viability nurses working within the acute sector, because a lot of what that showed was in regard to manual handling, about the shear, the friction, particularly when patients are being moved. So there's a link as well within tissue viability with infection control, as was mentioned earlier, but also with manual handling issues and making sure that they are right.
I think from the hospital point of view, it's often easier to do these sort of studies than it is in the community setting, because you have to a certain extent got a captive audience. It certainly fits in very much with the way healthcare has been delivered recently. If we're looking at acute admissions, particularly planned admissions, we now look at pre-assessment clinics, and it would be possible for us to actually set up trials looking at the information that's given in pre-assessment clinics to enable people to be prepared before they come into hospital. I can think of a classic example that we have, or we had a little while ago, was that patients coming in for orthopaedic surgery for knee and hip replacements, we as clinicians know have problems with swollen legs post-operatively, but so many of them actually came in with brand new slippers, because they're coming into hospital, must have new slippers.
Yes, of course.
And the new slippers don't fit once you've got a swollen foot. And it had a direct link then to the development of heel sores in these patients, where their feet were in slippers that were too tight, so they didn't wear them, or they moved the back off, so they were then sitting with their feet on hard floors. And that was a very basic issue about educating people during their pre-assessment clinic. And that fits in very nicely. Now, it's not work that's been done to date, but I think it's certainly a research project that could be undertaken quite easily.
Very much so. I've got Plymouth again on the line, I believe. Hi there, Plymouth.
Hi, everybody there. Just carry on with that conversation. It's really interesting, this stuff about the education for patients, information for patients. The booklets that are available, are they sort of fairly standard? I mean, and the information that you want to get across, is it fairly standard, or is there a lot of variation between different client groups and between different people? The thing I'm wanting to get at really is there a role for trying to personalise the information to particular patients, or at least particular patient groups, or is the information very, very standard?
There's certainly a Department of Health booklet, a fairly basic one, I might hasten to add, but it's a fairly basic book which gives an overview of what pressure ulcers are and understanding a little bit more about pressure ulcers, and that's probably a good starting point. But I think that there is a role for individualised information sheets for certain client groups. In Plymouth we've done a lot with women during the perinatal period, because we recognised that there was a problem with some women developing pressure ulcers during labour, and so we've done some targeted work specifically at that group. There are other groups like children who are not considered normally a high risk group, but we know that there are children that develop pressure ulcers. Now we have more children that are surviving chronic diseases, diseases where they would have had a very short life before, now surviving into their teenage years and into adulthood, and they're going to be at much higher risk than they ever were before. And to my knowledge, certainly in the southwest, we don't have an information sheet specifically designed for that group. I know though there are areas like Great Ormond Street that have gone along that route. I think there is a role for sharing information, and it's going to be down to things like the national associations, the Wound Care Society, Tissue Viability Society, Tissue Viability Nurses Association, to actually help coordinate that sharing of ideas.
Does that help you, Ray?
Thanks. Yeah, can I just sort of follow that?
Please do.
I mean, you talk about different particular groups. Well, what about particular patients? I mean, is there a case where maybe somebody, has a certain other comorbidities, for example, where they may have to do something different from a patient that doesn't have those comorbidities? The thing I'm getting at is that we've done quite a lot of work before coming here, and I hope to carry on here, in trying to personalise information according to people's own particular medical history. Is that something that would be worth pursuing, do you think, in this context?
I'd love to see the work that you've been doing up to now, because I think that's really great. If we can go along that route, it'd be brilliant. Could I ask you a question? How have you actually managed to do that? Are you looking at information that can be captured via computer, or is this simply a sort of blank sheet that you add to?
Yeah, computer. I mean, we've mainly been working, well, the work we've done in cancer has been with taking the medical record, well, essentially it's computerised medical record, except that it wasn't computerised, we had to put it on the computer first. So using the computerised record, or using some sort of on-computer interview of some sort. So that's where I was wondering about the risk assessment thing. I know I'm confusing the two different nice guidelines here, but you know, is there some sort of online questionnaire that could be developed? Is it the sort of thing that patients answer, or is it the sort of thing that is done by the nurse or the other clinicians?
I think it's something that could be done, but I'm aware of the limitations that we have within healthcare. But it would be wonderful if we could have something that the patient filled out beforehand, put in their bits of medical history, which then could be expanded on by the nursing staff and the medical staff, but would actually generate the information that you're requiring, the risk factors, and giving them the information specific to those targets. I don't know how you think about it in community.
I mean, the same, I would say, as far as doing that sort of thing, yes, it would be very, very useful if we could have that information prior to the patient being brought in to a hospital, a community hospital, or even into a district nursing caseload. The difficulty is that many of the patients that are seen during a part of their ill health where they really don't want to know about filling in forms or giving over questions. They want to be looked after, they want to be cared for, and then that becomes the responsibility of the nurse to do that assessment. It is good to have pre-information, but I think that we have to realise that a lot of the patients that we do care for are very sick and want to be looked after, not overly questioned at that time. So I think we have to have some sensitivity over that.
Thanks very much. I mean, that seems to be a conversation that might be worth carrying on with after the seminar.
Yeah.
Thank you.
Yeah, I'd love to.
Thanks, Sharon. Yeah, very valuable indeed. And I mean, the slippers for me has hit home. If you can just avoid, you know, a few people going down with difficulties because of information with regards to slippers, for example.
I think there's a big issue there for healthcare providers, whoever they are, that pressure sores have been seen as very unsexy. And because they're bread and butter. Having said that, they shouldn't be. And sometimes we need to think a little laterally, and it's one of the problems that's been highlighted about risk assessment and sticking to pure numbers. We need to read around those issues. If you have a patient who's in your care who's had a spinal injury and had rehab, we could think, oh, they're at very high risk, we'll put them on a dynamic mattress. Yes. The moment you do that, you actually reduce their level of mobility, and in fact you make them more at risk. Yes. So it's being able to not only just do the assessment, but actually see where that fits within the whole care package. And that assessment has to be about the whole patient, not just one part of it. We've got to look at the whole patient. I think as TVNs, one of the issues that we have is getting that educational point across to healthcare providers, for us to actually make sure that the information that is given out, whether it's in booklet form, whether it's on one-to-one interviews with patients, is actually relevant, and that the nurses and doctors, mustn't forget those, and the physios and so on, are actually targeting those areas.
Certainly with my nurse educator hat on, I can feel something interesting coming along with regards to the tissue viability and leg ulcer courses that we're currently running. And you know, why not consider looking at very different forms of assessment and assignment for our students, perhaps focusing on some of the factors that we've raised today.
I mean, that is a perfect opportunity, because some of the work that some people do on the MB courses, they have felt, well, they've done the work and it's then over. However, there have been a number of the district nurses that I've worked with, and a couple have had their work published. Yes. And I think that that's helping them to move forward. It's something that helps them feel better about what they're doing and think, well, I made a difference. And at the end of the day, that's why we're all here today.
Yes.
And that's why the NICE guidelines have come up, and that's why everybody's out there. We all want to make a difference.
And I think that's an excellent point to call today's seminar to a close. I'd like to offer my thanks very much to Jenny for her most valuable presentation, and to Martin and Maya for joining us today and really having some frank and full discussion. It's been very useful. I'm sure everybody out there has thoroughly enjoyed it. It now leaves me to just remind you of a few of our forthcoming events. December the 12th, we have Bob Gann, who is the Director of NHS Direct, online with us, talking around NHS Direct and some of the relevant issues. January the 16th, we have Professor Mike Hyland from the Department of Psychology with us, looking at new ways of thinking about complementary medicine. Also on January the 16th, we have Dr. Peter Drury with us, looking at an information strategy for the NHS. Those are just a few of our nearest events. We have quite a list of planned events this year, and I would encourage you to keep your eye open for what's coming up in the future and whether it is of interest to you. Thank you for joining us today. Look forward to seeing you next time. Safe journey home. Bye-bye.
Evidence from expert committees. So looking at first of all, the background to this study, the use of debriding agents and specialist wound care clinics for difficult to heal surgical wounds. The technology appraisal document talks a great deal about the factors that provided the rationale for the development of this guideline. First of all, most surgical wounds heal normally and quite quickly, but delays to healing are caused by a number of factors. Intrinsic factors such as the patient's any other existing morbidity, such as diabetes, their nutritional status, their circulation, their age, and so on, and local factors to do with the development of material or infection within the wound. We have no reliable epidemiological data on the number of surgical wounds that become difficult to heal. There are around 6 million surgical wounds every year in the NHS in England and Wales, and it is estimated that there are probably 21,000 become difficult to heal. Hello, good afternoon. For the first part of this presentation, I'm going to be looking at the research-based evidence that supported the development of the NICE guidance on debriding agents and specialist wound care clinics for difficult to heal surgical wounds. And then I'll be looking at the evidence for the inherited guideline on pressure ulcer risk assessment and prevention. When constructors of guidelines, when authors of guidelines on the clinical effectiveness of a treatment or an intervention, what they want to find is good quality randomized controlled trials. Randomized controlled trials that produce valid, unbiased and robust evidence for the effectiveness of the particular intervention or treatment. A randomized controlled trial is a trial in which subjects are randomly assigned to either the experimental group, the intervention group, or the control group, and then the outcomes, the dependent outcomes, are compared between the two groups. One thing that will set the authors will really light their fire is to find systematic reviews, that is a collection of randomized controlled trials that is going to provide good, sound, quality evidence for the particular intervention that they are planning. systematic reviews are important because they have very clear selection criteria, they're very comprehensive, and they also use explicit guidelines on how they appraise the information, the studies, for methodological rigor. When we're looking at evidence for the development of guidelines, often people talk about a hierarchy or a continuum of different levels of evidence. And right at the top, what researchers really want to find, or what guideline constructors really want to find, is strong evidence from at least one systematic review of randomized controlled trials that support the intervention and that there is a low risk of bias in those studies. And going down the scale, we move from strong evidence from well-designed randomized controlled trials to descriptive studies and evidence that is perhaps more informal and based on the clinician's expert opinion, clinical experience, and so on.
Wounds, plus the clinical guideline on the pressure ulcer risk assessment and prevention. Jennifer's presentation will be followed by studio and site discussion. Joining us to assist in our discussions are two experts in the field. Maya Fear, Tissue Viability Nurse Specialist for Plymouth Primary Care Trust, South Hams and West Devon PCTs, and Martin Butcher, Skin and Wound Care Service Manager and Clinical Nurse Specialist at Plymouth Hospitals Trust. Thank you very much for taking the time to be here. I'm also very aware that there's considerable further experience and interest locally in both the Institute of Health Studies and the wider peninsula. Those of you who fall into this group, please do make contact with your comments and queries to add to our debate. The telephone number to call is 01752 233 646 and the email address is studio@plymouth.ac.uk. Calls will be received following the presentation, which will be about 2:30. Please do share your thoughts. Your contributions are most valuable. Now, without further delay, I'd like to hand over to Jennifer. Hello, and welcome to another in the series of the National Institute for Clinical Excellence, NICE, seminars delivered from the Institute of Health Studies in Plymouth. Last time in this series we enjoyed receiving information from Dr. Morag Prowse from the Institute at Plymouth regarding the treatment of morbid obesity and the NICE guidelines relevant to the subject. If you missed that, don't worry, there are video copies available of that session for viewing. These copies, and those of other IHS seminars, are kept on each site for perusal and teaching purposes. This month's NICE seminar will be delivered by another of our Institute of Health Studies colleagues, Jennifer Kevern. Jennifer, who's Senior Lecturer at Exeter, will consider the NICE guidance on the use of debriding agents and specialist wound care for difficult to heal surgical wounds.